we're going to go ahead and get started. My name is Barry Servette, and I am the medical director for McPap. And I am very pleased to get us started with our clinical conversations session today. So, as you all know, we always generally meet on the fourth Tuesday of each month. Just to give people a heads up, the next one is April 25th, and the topic will be on postpartum depression screening in the primary care setting during infant well child visits. And so save the date. Uh, Today, we are actually really pleased to have Dr. Michelle Dalal presenting, and her topic is improving screening, diagnosis, management, and treatment for teen depression. So I'm going to go ahead and introduce her. Before I do, I just want to do some housekeeping. One is just to acknowledge, sadly, that we don't have CME credit available at the moment for this session. That we are always recording the sessions, and please know that they're on the McPap website shortly after they're completed. So if you want to recommend it to your friends and colleagues, let people know that they can find the session on the McPap website, as well as the slides. As always, we are very eager to have questions. Our presenter today is going to pause periodically for questions, but you can always feel free to enter them in the chat. Actually, enter them in the chat, either way. And we'll read them for you. If you'd like to read them yourself, we can unmute you as well as an alternative. So use the chat for questions. Please remember to answer the brief survey after the presentation. And now I'm going to introduce Dr. Dalal. So Michelle Dalal is a pediatrician and an associate professor of pediatrics at UMass Chan Medical School. And she just made a transition for the past 2 decades. She has worked as a general pediatrician at Reliant Medical Group. However, she just made a transition and is currently the medical director of the University Health and Counseling Services at Northeastern University. She's board certified in pediatrics. She has a certificate in lifestyle medicine through ABLM, and she has advanced certifications in motivational interviewing and culinary coaching. At the Mass Medical Society, she is the chair of the Committee on Mental Health and Substance Use. And she also is involved in the Mass chapter of the American Academy of Pediatrics Oral Health Initiative and the WDMS delegate to the Mass Medical Society. She recently wrote a book co-authored a book called The Teen Lifestyle Medicine Handbook, The Power of Healthy Living. She has done research focusing on integrating lifestyle interventions into the routine care of adolescents and young adults with depression, and has created an 8-week intensive virtual program for adolescent depression called LIFT, Mood Lifestyle Interventions for Teen Mood, which I'm sure you'll hear about today. She's spoken locally, nationally, internationally on lifestyle medicine and prevention, management and treatment of chronic disease. And she's also collaborated with colleagues in developing a toolkit for clinicians to help address adolescent depression as well as pediatric obesity through the integration of lifestyle medicine. So we are really honored and pleased to have Dr. Dalal, and I'm going to hand it right over to her.
All right, great. Thank you so much for the kind introduction and allowing me to speak on practical strategies to address teen depression. Just as some of the objectives for today's talk, we'll be reviewing a framework to approach mental health in the clinical setting, summarize key changes in practice workflow to allow improved screening and diagnosis of teen depression, and outline strategies for management and treatment of teen depression, including lifestyle interventions, group interventions, and digital interventions. So, I just wanted to stress that, a lot of this work was possible because of the commitment of leaders in our organization to, really focus on mental health in the pediatric population. And a key strategy for us was to prioritize behavioral health integration at any and every level, knowing the benefits of that in providing good mental health and physical health care within our settings. And there was really a desire to ensure that collaboration between our behavioral health teams and our medical teams to ensure delivery of accessible and high quality mental health services, and identify both pediatric and mental health leaders within the organization who were willing to ensure the delivery and integration of those services, and ensure we created these workflows that so that everyone, it was easy for us to integrate mental health delivery routinely. And so, as part of the initial stages of the work, we decided on services we wanted to prioritize, and we developed a mental health framework to address some of these issues. Providers were then trained to be able to follow this framework, and we wanted to make it very consistent so people knew that these were sort of the expectations coming in when we wanted to address any of these mental health concerns. And that framework is really as follows, asking about the concern and gathering the information that was needed from whether it was school, the caregiver, the patients. We wanted to make sure that everyone was aware of the types of screening tools that were available, and that includes those routine screenings like the SCARED and the PHQ-9, and perhaps additional screenings that could be used in that setting. And we wanted to make sure that people were aware of, how to really go about conducting those clinical interviews, and observing and understanding the way that body language influences the discussions that we have, and how that could impact the type of mental health diagnosis that we might make in any setting, whether it's through a telehealth setting or through an in-person setting. And it was really important for us to have patients and families learn the importance of screening and the rationale for them. And it was important for us to review those reasons for doing it and phrase them as a mental health screening, even when no concerns were identified. We wanted to make sure that our patients knew we were always doing a mental health screening through every clinical visit in some way, shape, or form, particularly during our physical examinations. And this will particularly become relevant, we think, as we start discussing the upcoming mandates for annual mental health wellness exams within the Commonwealth. Next steps, of course, we're completing, as we were saying, that clinical interview using our open-ended questions and looking for any type of functional impairment. And this type of training was delivered jointly by both the pediatric and psychiatric leadership, again, showing that integration and collaboration between us. And after gathering this information, we would sort of determine the urgency of the situation so that we could refer to urgent services if needed, such as the crisis intervention teams or mobile crisis. And if not, we developed collaboratively an action plan to address concerning issues. With that information, then we could suggest various interventions. And oftentimes our interventions were tiered based on the severity of symptoms in any given, diagnosis. And sometimes we weren't always able to make a diagnosis, but we thought we had ideas of what that diagnosis could be, because it was sometimes hard to make the diagnosis during one clinical visit. And of course, these interventions included those traditional interventions such as psychotherapy and or medication, but also included some, maybe what some might consider non-traditional interventions such as lifestyle interventions, digital interventions, and group interventions. And lastly, we completed the visit by ensuring appropriate documentation and follow-up of the concerns. And in order to do this, we spent a lot of time customizing our EMR. We had Epic, and we updated our problem lists and scheduled routine follow-ups for concerns with our medical and our BH team. And follow-ups were really something that we thought were very, very important, because it was easy to see that there could be improvement or worsening of symptoms fairly quickly. And we wanted to make sure that there was always a follow-up scheduled in some way. And we chose to use a full collaboration model when we in supporting this work. And There are lots of levels of behavioral health integration that can occur. This is our report from the Mass Medical Society, really highlighting some of the ways to integrate mental health and substance use care within our practices. And you can see that there is opportunity to really have from minimal collaboration all the way to full collaboration within any given practice. And again, we chose to have full collaboration in order to ensure that we would be able to have our mental health team work with us on a day-to-day basis in addressing the concerns that were being brought up to us in a timely manner with the least stress to providers and our practice. And as part of our team, we ensured that all of those who provided care to the patients were included in our discussions. And we wanted to ensure that parents and caregivers, or parents or caregivers, felt listened to when they voiced concerns, whether that came, from the first time they stepped into the building, from that first phone call that they made to us. So we wanted to ensure that everyone knew that this mental health care was important. That included our front staff, our medical assistants, our nurses, our providers, and of course our mental health team. And we spent time training our nurses to triage calls through templated notes. We were also able to refer, again, to a very robust mental health team that included behavioral health consultants, care coordinators, and a psychiatrist or a prescriber when needed. So again, that's sort of our model, is that there would be an initial consultation with the primary care provider, and that would direct referral, if needed, to a consulting psychiatrist or prescriber. But that wasn't always needed. We could sometimes just use an e-consultation practice where we could, ask a question if we needed to. And when there were sort of higher level of need identified, we could make a formal referral to them. We also have at each of our sites at Reliant an on-site behavioral health provider and a care coordinator for community referrals and other services that are needed. And in order to be able to really help all our providers learn how to screen and manage depression, we did embark and design a QI project with MOC credits so our medical providers could do this in a standardized way. And we wanted to actually be able to do this during our primary care well child visits, as well as during independent consultations. And so we developed, a list of goals that we had. This is 3 of the 6 goals that we had at any given time as we developed these QI projects. We had a robust timeline. This is actually a different project that we're working on right now, still through, I still do some per diem work at Reliant in order to, we're developing a anxiety QI project. And that helped our providers be able to complete the tasks that were needed to, finish that QI project. Our depression QI project ended, I'm trying to think of 2021 at this point, and we were able to publish on that. But just to kind of go through what our protocol was in terms of depression screening, diagnosis, and treatment in that population, we would screen broadly with a PSD-17 or a YPSD-17 so that we were capturing any issues, hopefully, that were occurring in terms of anxiety, depression, attention issues. And when those overall scores were high or the internalizing score was high, we would make sure there was a secondary screen of a PHQ-9. And then being able to score that and understand those symptoms would help us be able to tell approximately what severity of symptoms that a patient might have. And we had a list of follow-up steps that we would complete after that, which included, doing that clinical interview and ensuring that everyone had screening for suicidal ideation. And then that was followed by specific steps we were trying to encourage everyone to take, which included those referrals we talked about. And then in particular, we first started with these lifestyle modifications, which I'll talk about shortly. So again, changes to our EMR template were key for us to be able to do this in a standardized manner. And so once someone recorded that their PSC was positive and their PHQ-9 was positive, it would take providers through a list of choices afterwards to ensure that each portion of what the expectations were was actually completed. And with that, we were able to make sometimes, again, a diagnosis. Sometimes we would have to wait to a follow-up visit in order to do that. I'll be talking probably for the next, portion of the talk, really more on interventions, but I wanted to see if anybody had questions on the QI project or anything that I'd spoken about. Okay.
Looks like there's nothing yet, Michelle. Yeah.
Okay, sounds great. Thank you. Again, there's multiple interventions that could be completed, and I'll be speaking more about some of those non-traditional interventions. And one of those is really talking about lifestyle interventions for depression. And through our work with the American College of Lifestyle Medicine, we have developed a lifestyle medicine toolkit. And for those who may not know a little bit about lifestyle medicine, it's really talking about those things that we probably routinely talk about during our well child care, but finding the evidence base behind it and its link to how it can help depression was really important, and was a good way to sort of bring up various topics with our teens and our parents. And the reasons to really include lifestyle interventions are because those interventions are are actually evidence-based to a large degree. They're cost effective, and of course they're readily accessible. We don't have to wait for a psychiatrist to have an available appointment or a counselor to connect with us. These changes can occur immediately if there was desire to make those changes. And although they're common sense approaches, as we know, it can be difficult to make habit changes that can influence and improve both mental and physical health. We also found lifestyle interventions to be very easy to understand. And we found them to be culturally sensitive in the sense that some people in particular cultures were very resistant to be accepting help through a counselor or even going to a psychiatrist. And we found this was a good way to bring people in to at least talking about mental health and the need to improve their mood. And it was acceptable. And so lifestyle interventions fall into 6 main categories, which align with the 6 pillars of lifestyle medicine. This includes healthy eating, increased physical activity, improved sleep, stress management, promoting substance use cessation, and increasing social connections. I'll speak very briefly about each of these, as some of you may have heard some of this previously. So healthy eating, as we know, is one of the key pillars of lifestyle medicine, and specifically promotion of a plant-based or plant-predominant diet, whole food diet. And as we know, even current dietary guidelines do encourage lots of fruits and vegetables. And it was great to see that studies actually show there's a decreased risk for depression, and actually it may be protective for mental health if you're having healthy dietary patterns. And in fact, there are studies that show that the standard American diet is associated with increased mental health problems. And this includes adolescent depression through biologically plausible pathways of adiposity and inflammation. And so this type of discussion is often helpful during our talks with our teens and parents. The second lifestyle intervention to help both depression and anxiety is to focus on physical activity. And just there are many studies out there that show that exercise can help moderate some of the effects on depression symptom reduction. And one of the studies that was done over the past decade showed that each 50-minute increment increase in exercise per week was associated with a 50% decrease in the odds of being classified as depressed. And even something very simple, such as replacing sedentary activity with light activity, can improve mood. So again, the physical activity guidelines that we can find are really important as something to discuss as a possible intervention. And the next intervention is sleep and really improving sleep. And there are 3 particular characteristics or predictors of anxiety and depression. And that includes sleep onset latency, the total time of sleep on school nights, and the late sleep chronotype, meaning that they tend to want to sleep later, and then they are more likely to experience anxiety and depression. And again, we talk about some of these things, but it's great for sometimes teens to know that keeping a consistent schedule can make a big difference. And in fact, the time of waking may be more important than the time of sleeping. So even though they sleep late at times, if they can keep their wake time consistent or within an hour of their normal wake time, that can actually keep their sleep patterns in a good rhythm. And of course, things such as keeping screens off at night. Some of the recommendations through AAP are for 30 minutes prior to sleep, but in fact, there might be effects for up to 60 to 90 minutes before sleep, and things like avoiding caffeine at night may be other topics to continue to discuss. And then, of course, treating insomnia improves depression, and insomnia, as we know, increases suicide risk, poses risk of suboptimal response to traditional depression treatment, and it can increase the risk for major depressive disorder relapse. And we do know that there are sleep specialists who can help with this. And of course, there's cognitive behavioral therapy for insomnia, which is an evidence-based measure in order to help with insomnia. And these are some things that can be done within the office, and some of the goal setting, sleep journals for teens to bring back to us to sort of discuss how to improve their sleep. And of course, there's advocacy that can be done at the community level in order to influence policies such as later school times, which may be helpful. And the next pillar is substance use cessation. And we know that both treatment of both substance use and depression helps improve outcomes. And there are studies which show that kids who have mood issues are more likely to use, and once they start, that treatment of both the mood and substance use is needed to have better outcomes. And that nicotine, alcohol, and cannabis use increases risk of depression and anxiety. And there are studies that show that people who vape nicotine are twice as likely to be depressed. Next is, of course, our improving social connections as one of the interventions that we can encourage, because we know loneliness increases the risk of depression and anxiety in adolescence. And some of those things that could be encouraged are time with family and friends, even with pets, the community, volunteering, encouraging peer support groups in the school settings, and of course, other clubs and activities where they can engage with others their own age. And then lastly, of course, stress management and working on those aspects that may be helpful, and finding what it is that teen can do in order to decrease the stress that they're feeling at any given time. And also helping them remember that stress can be good or bad. The perception is always is that we can't have stress, that may not be good for us, but helping them understand that can be really important. We were able to publish on that in the Harvard Review about some of these lifestyle interventions for adolescent depression that did have evidence backing them. And it's a good resource in order to see the many things that we could discuss within our clinical setting, along with other group type interventions that can be implemented, oftentimes in a school setting, but potentially can be transitioned into a clinical setting if desired. So I'm going to stop there just for a second if anybody has questions on lifestyle interventions before I move on to our group intervention.
Hey, Michelle, there was a question sort of at the very end of the last section of your talk about the PSC, and particularly differences between the PSC and the YPSC. I don't know if you want to speak to that now or.
Yeah, there are very few differences. It's just a few words that are different, that are more geared towards the adolescent population in the YPSC 17. So it's relatively, it's just a bit of a difference. And
Yeah,
so that one's one that we wanted to use in our older adolescent population.
yeah, that was my impression as well.
Great.
Okay. No, there's no other questions. Actually, the clarification about that question is really around the score difference. And so,
Yeah, the score difference is actually not very different in terms of the total scoring. And John, you can maybe speak on this, but it's the same scoring. You still score based on internalizing You can do subscores, I should say, on internalizing factors, externalizing factors, and attention scores also. And so the scoring is similar.
So, Sufan, if you wanted to ask any more clarifying questions about that, we can always do that at the end as well if there's time. I don't know.
Absolutely.
Yeah. Okay.
Yeah, there'll
Great.
definitely be time. Um, so I wanted to talk a little bit about our group intervention. And so one of the things that we wanted to do was try to reach a larger number of individuals over time. And we were hoping that the peer support that teens might get from others within a group intervention might help them adopt healthy lifestyle habits. And so we were able to design a group intervention called Lift Mood, which is lifestyle interventions for teen mood. And it was really an intensive lifestyle modification curriculum for teens to prevent and manage adolescent mood. And the components of that included a set of PowerPoint presentations, discussion with those who participated in that group, a teaching manual for instructors to help them understand how to deliver the information in that evidence-based manner, and a participant binder for teens. We would meet for approximately 75 minutes weekly for 8 weeks in order to review the various components the various topics that could help them with their depression. And this is our sample manual that's probably about 20 to 30 pages that really has each of the slides and what someone could say or do or talk about at each session in order to encourage conversation. We also had that participant binder. And so you could see in the center table of contents what each of the 8 sessions had in terms of topics. And so it included all those lifestyle pillars that I just mentioned. It included a little bit of cognitive behavioral therapy also. And it included this culinary coaching to really help, hopefully have them have a little bit of fun in preparing a snack, and also really understanding how, eating well can influence their mood. And it was interesting to me as we participated in these groups that a lot of the teens knew what would help them, but of course, as we know with all these habits, it was hard to know how to incorporate them into their daily life. And so each of the sessions also included various activities that they could participate in. And so they were written out again, so that the delivery of this could be done on a routine basis. This was delivered jointly with a pediatric and a mental health provider. The billing was through mental health only at that time because it was a little bit hard for us to document the reason for billing with the pediatric provider alone. The mental health provider did that billing, although the first and the last sessions could be billed through pediatrics because you were doing a lot of sort of assessment of their PHQ-9s and brief review that you could document. And so we were able to bill at least for one of those sessions with the pediatric provider. We decided on a max of 8 participants so we could encourage that robust conversation. These occurred after school. These occurred in a virtual format because we were still in the midst of sort of the end of, or I don't know if we call it the end of COVID, but at the tail end of the ongoing COVID epidemic or pandemic. And we did have involvement from parents for the last 1 to 2 sessions, which we found helpful to have the teens be able to describe what they did during the sessions and what types of goals they were hoping to achieve when we talked about improvement in mood. We were careful about who we actually enrolled in these sessions. And so we did have criteria for enrollment, which included anyone typically with mild to moderate symptoms of depression, and also those who did not have active suicidal ideation. And we only offered these classes in English initially in order to ensure that what we were presenting was deliverable. And so prior to my departure from Reliant, we were able to complete 2 full 8-week sessions. And of those completed sessions, all who participated had either improvement or at least maintenance of their PHQ-9 scores. And we thought that that was really important because some of the things that we do may not, make you not depressed, but at least if we can manage it and keep the teens from getting worse, we thought that was a successful outcome. And some of the challenges we did have for those who might be considering doing these group sessions is we did find that the teams did want to do in-person sessions. They would have preferred that actually. And because ours was a virtual group model, we thought that that was a bit of a challenge to deliver the type of information we needed, but also to do some of that culinary coaching that we were trying to do with them. Buy-in from an administration, we initially did get a lot of that, but continuation after, particularly once I had departed, was a bit difficult because we couldn't necessarily show that there was a monetary well, two things. One, there wasn't necessarily enough participants for us to show financial gain from the administration of these types of group settings. And perhaps in the new environment, well, there'll be more funding, hopefully, in primary care to be able to do these things. That won't be as much of a reason not to do these types of sessions. And then, of course, the timings for the groups were hard because we did do it after school. Some of the patients had to work. Some of them had difficulties just in terms of being home on time. And so sometimes we found that there was mixed participation within that group. But for those who did participate, it was a very enjoyable experience. We found that most people completed 6 out of those 8 sessions. And initially they were able to keep our teen lifestyle handbook, which is available for everyone for purchase. And I don't get any funds from that. It's actually sent back to American College of Lifestyle Medicine to offer scholarships to train others about lifestyle medicine. But it was one of those things that we initially offered, but afterwards we just chose that participant binder as our primary tool to do those activities that we wanted. So I'm just going to pause there to see if anybody has questions on the group intervention.
I don't see anything there in the chat.
Michelle, John,
yes.
could you make available where someone could get the handbook?
Oh yes, absolutely. I can put that. The handbook is available. You're talking about the Teen Lifestyle Medicine Handbook, correct? Not the course manual, not the group manual.
The binder you talked about.
The participant binder.
Yes.
Yeah, so the participant binder is something that I could send to you. And then if you wanted to be able to post that, because I'm happy to have people review the participant binder or even see the manual for instructors, if that would be helpful as a way to help others develop their own group interventions and modify what we did. The Teen Lifestyle Medicine Handbook is actually a published handbook, and that one has all the various lifestyle interventions, including some of the activities that we included within our group, and that one is available for purchase. That's completely separate.
I think that's what I was thinking mostly of, but I think all 3 might be useful, so that'd be great.
Yeah, for sure. Yeah, absolutely. I can send that.
There is a question in the chat about how you did billing.
Yeah, so the billing was done through our mental health, the mental health providers only. So it was billed as a routine session through them. And I don't know that I can definitely send specifics on that, but I believe it, like for me, when I did billing, for example, I billed it as a level 3, and that just included those things that we routinely would do during any typical depression visit as documentation. We did document after each group visit on each participant. So that was in the chart. And we did summarize sort of their interactions and their PHQ-9 scores at the end of the group visit to send back to the pediatrician. But again, they were billed all through our behavioral health team as visits. They said that it was just as they would do for routine counseling.
Thank you.
Mm-hmm. I also wanted to talk about other interventions. So we found it really important to make sure that we had lots of different types of interventions we could potentially do. So now we talk about lifestyle interventions. We talked about, psychotherapy, traditional counseling that we could offer, these group interventions. And we also were able to bring in some of these digital interventions, which many of you may know about. But I'll be talking a little bit about single session intervention. And then, of course, some of these apps that are available to all of us, the apps such as Calm or Headspace. And as many of you may know, Headspace is free for all teens in the US. You can get it through this peer health exchange. And so we found that helpful to know and be able to direct teens to that, so they might be able to use particular aspects of that in their management of their depression. Other digital tools that we found were helpful is these few apps. Dalio helps to design some goals, especially particularly since we were helping our teens make SMART goals at the various group visits. We wanted to make sure were having a way to document those, and Dalio helped with that. Again, Calm, MyFitnessPal for those who wanted to sort of look at the nutrients within their own diet, and other exercise apps for those who wanted to find maybe quicker ways to participate in physical activity if they were unable to through sports, and just being able to do it on their own. So I wanted to talk a little bit about single session intervention for depression and anxiety. So we worked with Jessica Schleider's group out of Stony Brook in order to bring to our patients this single session intervention. They have what they call a lab for scalable mental health, and it really was a nice, simple way that some of our patients could do some self-guided modules in order to help with their depression and anxiety. So single session intervention is a brief 30 to 40 minute self-guided intervention shown to reduce symptoms of depression, anxiety, hopelessness, and restrictive eating for a short-term period. And they offer it to patients ages 11 to 17. And our focus was to offer it on patients 13 to 17 because we were doing a bit of a feasibility study. And this is available in both English and Spanish, and it's freely available. In a nationwide randomized trial, 2 of the online single session interventions in this project, significantly reduced those depression symptoms, hopelessness, anxiety compared to a control. And teens who took part in this project, in another study, were found to have, again, improvements in hopelessness, self-hate, perceived control, and agency. And so we thought it would be another great intervention to be able to offer, particularly maybe for those who were waiting to get into counseling, maybe for those who might not feel comfortable being in a group intervention, but who had mild to moderate symptoms that were, somewhat concerning. We wanted to make sure they had something that they could potentially do. And so we spent time in really educating our providers about single session integration or interventions, and then building it into our office workflow such that when the patients had elevated PHQ-9s and then eventually GAD-7s, we could potentially offer this as an intervention for them. And we use these pop-ups called best practice advisories for selection of these various interventions. And this was one of our choices. And if you wanted to read like a full description of our protocols for this, we have a preprint that is available for viewing online, that's in the JMIR protocols. So, and as part of that, we had discussed changing our EMR to ensure that we could bring to everyone and help them know everything that's available at any given visit. And so again, we changed our Epic smart phrases such that we could incorporate all the various offerings. So it'd be easy for our clinicians to identify what they could potentially use for their patients. And I guess just as a final note that as we know, every teen's unique, and we really want to consider an individualized menu for them of options. And so we thought it was important to continue to build upon these interventions over time. And lastly, that there's lots of opportunities to influence delivery of mental health services, and really at every level, whether it's individual, family, community, environment, societal changes. There's lots of things that we can do to shape the mental health of young people. And hopefully, some of these interventions that we have, we can continue to share and continue to help the rates of depression that we're seeing. And I will be open for questions.
Right, so we're monitoring the chat, and we'd be glad to unmute anyone if you request that. It's a quiet group today.
Yeah.
Michelle, could you speak a little bit how the acceptance was of doing this amongst the group? Yeah.
The teens or the providers?
Providers.
Yeah, providers. They were on board. We were getting a good number of referrals for the group interventions, for the SSI. Initially, they were wary about the number of things that we could potentially offer and how many pop-ups might come up, at any given time. But I think that as they realized that there was additional opportunities that they could take advantage of in given settings, that helped actually offload some of the potential concerns that they had. And we just wanted to make sure that we made it easy for our providers to feel that they were able to do something for their patients at any given time. And so the ongoing education, again, was helpful, particularly because our pediatric leaders and our pediatric director was willing to continue to ensure that we were, delivering this type of education on a regular basis. And I think they realized that because we do it so routinely, that that integration of mental health continues to be just on the forefront of the things that we care about within our particular clinical setting. The last comment I make is, these group interventions, I think we are starting to see that hopefully we'll be able to continue to progress to doing more of them over time. And now I'm in a new setting, as we were stating before, in a college setting, in a university setting, and the hope is to really offer some of these types of interventions there also. So I think there, potentially that there's opportunities to adapt some of the information to any given setting if that was something that individuals wanted to do.
So we have a audience member who says, my current crusade is to try to help teens, especially depressed teens, sleep better, but it's often a refractory issue. Screens, peers up at the same time, telephone calls. Do you have any tips about, talking with people about sleep? I think that's very true.
Yeah, absolutely. I think a lot of it is, so I think when we kind of get into these discussions with teens, and the question is, are they bringing some of that up, that their sleep is a concern? And so we sort of bring it back to them in terms of, well, how do you think your sleep is affecting you? And oftentimes there's pretty good insight with many of the teens that we find. And then they understand sometimes if we can make that connection between the poor sleep and then having the difficulties the next day, or how they feel the next day. So really trying to bridge their feelings on, that next day when they're not getting good sleep. And then really asking them, and letting them know that sometimes this really can influence their mood over time, as they are stating, and being able to really help them develop their own goals, I think is important, rather than us sort of listing those types of types of goals that I had listed myself. And sometimes having them be able to do that on their own helps them move in that direction. The other thing that I found sometimes helpful with some of the teens, it was helpful to be in the group actually, because they made suggestions to each other about what could be done differently. And then also, if they have support from their families about making some of these changes, and it's really some like a bit of a family intervention, that sometimes can be helpful also. That all right, all of us are going to do better with this within, within the family, because we all could, use some more sleep at this time. That's sometimes helpful also. The screen time thing I think is really, really difficult, because it's, as we know, it's hard to get them to turn off their screens at times, at night in particular. But again, really stressing that the way that this can interfere with their nighttime sleep. We'll just continue to have those discussions and see, even if they can't make the change of, again, 60 to 90 minutes or 30 minutes, like what type of change could you potentially make in order to help? And so just having that sort of open conversation and allowing them to take those first steps on their own is often a good way to kind of encourage them down that path.
Yeah. It's a couple of things that you said made me think about how behavior change, that it's really important to think about behavior in a systemic way, people are not really sort of isolated individuals, especially children and teenagers, they're embedded in systems. And so the most powerful of them, at home is the family, and so it can be hard to change behavior, or even for a teenager, if they want to change behavior, it can be hard to change if the system doesn't support it. When you talk about dietary changes, when you talk about changes in routines at home, it's really important to kind of involve the family. I think that can make a huge difference, because then you can sort of design some changes in the system. Like, for example, obviously, nutrition is probably the most obvious example of this, that it requires what's purchased at the supermarket, and who's going to cook the healthy food, and how is it going to be available, and that kind of thing. And the same thing with exercises. How is it going to fit in with someone's routines, and are other people in the family going to support that, and what's realistic, and how much money is there to spend on different kind of enriching activities and things like that. So it becomes very complicated, and sometimes you do have to kind of begin to talk about that kind of stuff with people.
Yeah, absolutely. And those systems changes, I mean, I think, as we know, it's much larger than what we could potentially do in any, clinical visit per se. And so really focusing on the advocacy that we can, the advocacy in general within our communities and at larger levels, I think is really important also, because if we can make those external changes, sometimes it's easier for us to make, routine changes. For example, having more sidewalks in our communities. I know that's a grant that was passed, at least where I'm living now. And so they were able to build more sidewalks, or having those things such as walking school buses, all these things. Again, you have more interaction with other people. That way you're walking more, you're hopefully getting exposure to sunlight, which is helpful for many. Nature itself can be thought of as another important lifestyle intervention, or exposure to nature, I should say, is an important lifestyle intervention. And so I think there's a lot that potentially could be done.
The other small kind of point that I've sort of thought about in regard to lifestyle changes has to do with, a lot of lifestyle changes are framed in kind of a negative way, like stop doing this, or you shouldn't eat this, and you shouldn't look at your phone and things like that. And so it's really helpful to not only frame it positively, but to try to talk about how these kinds of changes could be fun, and really enjoyable, sort of. And I think sometimes it helps to pair this with mindfulness kind of practices too, because a lot of people, if before they go to sleep, for example, they're using their phone, they're getting all activated and stressed and worried, and if you can coach people to do a mindfulness exercise like a body scan or some kind of breathing practice, people sometimes discover that it's extremely relaxing and enjoyable. That
Mhm.
so you're talking about what they can do instead of the thing that you don't want them to do, and talk about how enjoyable and pleasant that can be. Might not be able to get away with it, because it's not necessarily going to be fun for everyone, but I think that it's important to try to find ways of making people feel good about changes, as opposed to talking about all the things they shouldn't do that they think that they enjoy, which they probably don't.
Yeah, absolutely. And I think that, I mean, we could even think about that in terms of nutrition, like instead of telling people not to eat certain foods and not to do this, if they can just start adding in those fruits and vegetables at times when they, with what they're already eating, just adding in rather than, again, talking about removal might make a big difference in terms of encouraging those healthy habits. And so, and I think the same is true. We were talking, a little bit about physical activity and how sedentary activity or being sedentary is not good, but even that small change of just being able to get up a little bit and seeing how your body responds when you're able to have that routine movement, I think people really do see that change. And as part of our group intervention, we did a lot of that sort of looking at, we called it it was like a mood thermometer basically, in order to see how you feel at that moment. And so we did that pre and post physical activity, because the last 15 minutes of our group session was doing a physical activity type exercise that they were learning how to do. And it was interesting that they could see the improvements in their own mood, even with that brief burst of activity.
That's really nice. All right. Well, it looks like we have a little bit of time, a remainder of time for people to use, and so I think we can adjourn. But Dr. Dalal, thank you so much. It's a very interesting presentation. We really appreciate your presentation and taking the time to be with us. And thanks to the audience and to everyone, and to Jono and Beth, for their coordination, and we'll see people next month on April 25th.
Great. Thank you for having me.
Okay, bye-bye.
Bye.